In today's session, we're discussing a 60-year-old Caucasian male with a new diagnosis of non-small cell lung cancer. He presented initially to the emergency room with mild dyspnea and worsening dry cough. He had no significant past medical history, only hypercholesterolemia and hypertension. He had a social history that was interesting because he was a never smoker, but he had occupational exposure in the shipbuilding industry for 40 years. On physical exam, he was nervous and anxious appearing. He had mild dyspnea with tachypnea, roughly 22 respirations per minute, but otherwise an unremarkable exam. On initial imaging, the patient was found to have a right hilar mass on chest X-ray. This was confirmed on the CT of the chest, abdomen, and pelvis, in which he was found to have a large right hilar mass of 4.6 centimeters, a subcarinal lymph node conglomerate, and a right hepatic lobe lesion of roughly 2 centimeters that was deemed to be suspicious. He further underwent a PET CT that was positive for avidity in the liver lesion, and then he underwent biopsy of that right liver lobe lesion and was found to have a pulmonary adenocarcinoma. His molecular markers demonstrated a PD-L1 level of 50% and an EGFR exon 21 L858R substitution. So basically a phenotype that is not quite uncommon, a combination of two markers, and he was started based on the FLORA trial data on osimertinib 80 milligrams daily. He tolerated the medication well, and he had a very good response for about 19 months, at which point he was found to have a new isolated liver metastases, and he underwent further workup for additional treatment recommendations. The patient's diagnosis is a stage 4 adenocarcinoma of the lung. It's the most common subtype of lung cancer histologically, the EGFR being the only large targetable, currently at least, targetable subtype, which is a positive find for the patient. And that translates into an improved prognosis prior to previous treatments, with an expectation of roughly 36 months in median of overall survival.